you very much, Pablo. And I don't think the audience is necessarily aware of the fact that none of us knew what the papers were going to be from our colleagues. And I think it's really beautiful. We've had 3 viruses which we can now prevent: smallpox, measles, and influenza. And we've had the 2 Rons who both told us about the importance of the host in relation to infections and their responses. And I'm now going to talk about another virus and very much about the hosts in relation to that. And I want to talk about the ARROW trial, which was carried out by colleagues in Africa in the early 2000s. Now, if you go to the Lancet paper, you will see it's very beautifully written, it's very modestly written, and it's all about the numbers. But in these slides, I want to just also bring alive something of the amazing team of people who carried out this trial. Next slide, please. So ARROW started in 2007. And here you can see some of the great people who were there at the very beginning. Next slide. And watoto is the Swahili word for child. And at that time, only about 28% of children who needed to be on antiretroviral therapy were getting it. And one barrier to getting on treatment was the perceived need that children should be having routine laboratory tests. In resource-rich settings, we were doing blood tests, liver tests, hemoglobins, all the rest of it on children on antiretrovirals every 3 months or so. Already some trials in adults had suggested that in fact routine monitoring had only a small benefit in terms of CD4 counts, but really little benefit in terms of toxicity testing. But we didn't have any data in children. So this was the main trial question. Next slide. But this is an absolutely brilliant trial because it packed in a whole series of questions, not just one. This trial was undertaken and included over 1,200 children. In the Lancet paper, it just talks about the 2 first randomizations, but you can also see the papers for the 3rd and 4th randomizations. So we looked at whether children were on clinical monitoring or laboratory monitoring. We looked at whether children started on 3 drugs or 4 drugs using the available antiretrovirals at the time. The 3rd randomization looked at whether there was an advantage to children in an African setting to be continuing on daily cotrimoxazole. And the 4th randomization was looking at changes between once daily and twice daily dosing. Next slide. So this study took place at 3 centers in Uganda, 2 in Kampala and 1 in Entebbe, and 1 center in Harare in Zimbabwe. And the clinical trials unit at the UK was able to bring the data together. And this was a very sick group of young children with HIV. A third of them were under 3 years of age. 70% of them had either stage 3 or stage 4 disease, and stage 4 is AIDS. The median CD4 count was 12%, and the median Z-score weight for age was -2.3. So these were sick, malnourished children. Next slide. And it almost brings tears to my eyes to read through what you can see here. The median follow-up was 4 years. This was a very long clinical trial, and a total of over 4,500 child years of follow-up. And only 33 children were lost to follow-up. And during this time, actually, there was a massive cholera outbreak in Zimbabwe, but the clinicians and the trial team went on working through it. At the end of the trial, 95% of the children were still alive, and only 5% had switched to second-line treatment. Only 1% of them had a CD4 count of less than 5%, and nearly 80% of them had a viral load of less than 400. And these are outcomes which at that time would have been dearly beloved for those of us working in resource-rich settings. These were absolutely amazing outcomes. Next slide. So as we said, the study was comparing between the laboratory monitoring or clinical monitoring only. And in the clinical monitoring only arm, this was by nurses in the studies, seeing the children on a regular basis. Overall, there was no significant difference. And you can see particularly most of the significant events, so a new AIDS diagnosis or death, happened in the first year. And then if you look beyond the first year, there were slightly more events in children who were on the clinical monitoring, but this remained within the pre-specified non-inferiority margin. So this is a very important outcome. Next slide. If you look at what happened to the CD4 counts of these children, it's absolutely amazing. They gained more than 300 CD4 cells over time. And the percentage is also significantly improved. Next slide. If you look at the viral load suppression, again, you can see it was extremely good and there were no differences. And of course, people were very worried. Abacavir was used in this clinical trial for the first time in children in an African setting, and clinicians were very worried about side effects. But there was no difference in significant adverse effects, and there were very, very few issues of abacavir hypersensitivity. Next slide. So the conclusion of the study was that HIV treatment can be delivered safely to children with good quality clinical care and without the need for routine laboratory testing. And if you read in the paper, you can see all the details. And what this really meant was that it was to enable our colleagues to roll out treatment to children and make the very best of getting the treatment to the children rather than spending money on setting up laboratory monitoring. Next slide. So why did I choose the ARROW trial? Well, I chose it because, of course, it very beautifully answered the clinical questions that were set up in the randomized factorial trial. But this trial built so much more. It showed us, in terms of HIV care, how children could really thrive on treatment with amazing immunological and virological responses. It showed us new kinds of syndromes, such as children with iris, which presented as kwashiorkor. It helped clinicians deal with stigma. It helped us consider, how do you consent children who are orphans? There was a huge amount of sub-studies associated with ARROW, and including lots of pharmacokinetic studies, and all of this contributed to updating the WHO guidelines. There was a great deal of shared learning, training courses, beautiful films, training films, working with families and young people. Perhaps, though, the most important thing about this clinical trial was how it developed the local expertise. And clinicians who took part in this trial are now clinical leaders in pediatric HIV in Africa. It helped develop laboratory expertise, statisticians, clinical trialists, ethicists, psychologists, cost effectiveness expertise as well. And it was, I think, fundamental in rolling out antiretroviral therapy to children in low and middle income countries. So it's a really, really very special trial. Next slide. And this is a very formal picture of those of us who were there when the final results were revealed. And that was a very exciting moment. And I think in terms of the study, next slide, it was very exciting for those who wrote the paper that their paper was voted BMJ Paper of the Year in 2014. Thank you very much.